Okay. Good morning and hello, everyone. I'm happy to have been invited to give you a talk today on optimal breast cancer screening. Um, it's being recorded, so hopefully it'll be seen by many more colleagues than we're able to log in live. I'm going to focus on the issues in Canada, and these slides are accurate as of today, but things are changing quickly. There's been progress, but no province achieves the ideal. Please hold your questions till the end and we'll get to as many as we have time for. So I have no relevant disclosures. I'm here on a volunteer basis. I'm not paid by industry or anyone else for lecturing. I have no financial interest in any technology that's used for breast cancer screening, and all my statements will be based on the peer-reviewed literature. I do show references in most of the slides. So I'm going to discuss the benefits of early detection of breast cancer, how and why we try to find it as early as possible, and the possible risks of screening. I'm going to describe the discredited research done in Canada in the 1980s, which continues to significantly influence the Canadian Task Force in making recommendations for screening. I'll demonstrate the flaws and protocol deviations in that study, resulting in it now being under investigation by the University of Toronto. I will show you more modern research supporting screening starting at 40 and supplemental screening for women with dense breasts. The biggest obstacle to optimal screening is the Canadian Task Force. It's a volunteer committee that makes screening recommendations for primary care providers, and they're described as being experts. Now, most family docs and nurse practitioners are surprised to learn that the task force deliberately excludes content experts from all its guidelines panels. So there were no breast cancer experts on the breast cancer screening panel, no pediatricians on the developmental delay screening panel, etc. The task force is funded by the Ministry of Health through the Public Health Agency of Canada. For COVID, PHAC appointed experts to make guidelines for preventing and treating the disease, but they don't do that for cancers. The task force was set up so that they're arm's length and they are not accountable for their recommendations. The task force is currently reviewing the breast cancer screening guidelines, but the co-chairs have shown their bias in social media and mainstream media interviews. So there's great concern that they will not change the guidelines from what you see here. So here are their most recent guidelines, still in force from 2018. They recommend against routine screening for women 40 to 49. They recommend that women should be screened only from age 50 to 74 every 2 to 3 years. They recommend against primary care providers doing clinical breast exams and against women doing breast self-exams. They recommend no supplemental screening for women with dense breasts. Now, thankfully, many provinces do not implement all the guidelines. For example, in BC, women can self-refer starting at age 40 and have been able to do so since 1988. And women with dense breasts can have supplemental screening. But before we go further, I want you to hear from Shira Farber in Ontario, who's an unfortunate example of women who've suffered as a direct result of the guidelines. And in the interest of time, I've edited her video, so it's a bit choppy.
And then I turned 40 and I went for my annual checkup with my family doctor, who was a really, really wonderful family doctor. And I asked her about getting a mammogram. It was a simple, normal part of my checkup, like asking whether I needed a tetanus shot or a vaccine or a PAP. And I was advised at that time that Ontario's screening program had changed to 50 plus and that I wouldn't need a mammogram until I was 50. And I remember feeling relieved at that time because I was actually frightened to have a mammogram. I had heard nightmare stories about it being painful and uncomfortable. And now living what I've lived through, I find it pretty funny to think that this simple test has been made to be so scary to so many women. I wasn't aware at the time that 80 to 85% of women with breast cancer do not have a family history. I was also not aware that Canadian breast screening guidelines stated that the decision to have a mammogram is a woman's choice based on her values and preferences. Now I know that there's a significant education gap because many doctors and women seem to not know this either. And like me, some women are still being denied mammogram requisitions in their 40s. At the age of 48, just as we were beginning to surface from the pandemic, I felt something strange in my chest. It wasn't exactly a lump. It felt more like my breast was full of silicone, and that I describe it as, it felt like a Nerf ball was stuck inside of it. I let it go for a few days, and then my husband noticed it, and I realized I couldn't really let it go much further. So I called my family doctor, who immediately referred me for a mammogram and ultrasound. But because of the pandemic, I couldn't get an appointment for about 6 weeks for a mammogram. When I did, it was apparent it was breast cancer. A biopsy was taken, 3 large tumors were found, and I was diagnosed with advanced stage breast cancer. And I then began my treatment protocol a few months later. My treatment consisted of aggressive chemotherapy, a mastectomy with no option of immediate reconstruction, a complete sentinel node dissection of almost 40 nodes that resulted in permanent lymphedema of my arm, followed by radiation. Most recently, I underwent a mastectomy on the contralateral side and a complex reconstruction using my abdominal tissue. I suffered serious cardiac-related issues from radiation treatment, and I required weeks of hospitalization. My joints have been severely impacted by chemotherapy and hormone therapy drugs. Stairs are a challenge for me, as are long distances. To prevent the risk of recurrence, I continue to have treatments that can result in serious side effects, including jaw necrosis. I am doing everything I possibly can to avoid a recurrence so that I can be around to enjoy this next phase of my life. I want to see my children flourish as adults. I want to have grandchildren. And I want to grow old with my husband. Sorry. The physical and emotional side effects of treatment have been debilitating. The impact on my family is secondary cancer. I wasn't able to work for over a year. I almost lost my business. I incurred tremendous debt and legal fees to get back on my feet. My husband had to reduce his workload to care for me and our children. 2 of my children required therapy to cope with the situational anxiety and stress, and I could no longer be a caregiver to my mother. I have met so many incredible women, also blindsided by a similar advanced stage diagnosis. 2 of them, who I shared a very close relationship with, actually we all belong to the High Lifeline support group together, and 2 of them unfortunately died within the past year, and they've left very young families behind. If you had told me a few years ago that I'd be advocating at all levels of government on this issue, or speaking to the media and doing educational webinars like this, I would have told you were crazy. I've always had a big mouth. I've always advocated for friends and family, but I've never really advocated for myself. I was also quite shy about my body, and I never really wanted that kind of attention drawn to myself.
So in Ontario, women in their 40s can have a mammogram if they get a requisition. But even in British Columbia, where a doctor's requisition isn't required, we know of women who are advised against having screening by their family doctors and had the same scenario, being diagnosed with an advanced stage. Only 25% of eligible women aged 40 to 49 are having mammograms in BC. So I can skip the basics on what cancer is, but I'll remind you that breast cancer doesn't become life-threatening when it's confined to the breast. Many breast cancers can be found before they spread, and when they are, there are 2 benefits. Women are less likely to die, and they can be successfully treated less aggressively. The first goal of early detection is to reduce deaths. The proof that screening mammograms save lives was established by multiple randomized controlled trials. We've been studying mammography for almost 60 years. The trials in Canada were done over 40 years ago. So bear in mind that all of these used X-ray film mammography, which has been replaced by digital mammography everywhere in Canada. And the treatments available then were considerably less effective. Yet these old studies proved that mammography screening reduces mortality from breast cancer. Even though the trials were of different designs, they are usually lumped together in a meta-analysis. They included women from age 40 to 74 and showed 15 to 20% fewer deaths in women in this age group who were invited to have mammograms. The 2 from Canada, outlined in red, were the only ones where women were more likely to die of breast cancer if they were assigned to the mammogram arm. I and my colleagues are working to get them retracted from the literature, and that's essential because until they are, they will continue to be used by the Canadian Task Force and policymakers in many other countries to deny screening for early detection for women aged 40 to 49. There were 2 Canadian studies. CNBSS1 was for women aged 40 to 49. The study group had annual mammograms and clinical breast exams, and the control group just had usual care in the community. The eligibility requirements were age 40 to 49, no previous history of breast cancer, no mammogram in the previous 12 months, not be pregnant, and sign a consent. But women with lumps were welcome to participate. So from the start, red flag number one, this was not properly designed as a trial of screenings for women with no symptoms and no lumps. All the other randomized trials were population-based. Some women were invited to attend for a mammogram, and they were the study group. The control group didn't know there was a study going on or that they were in the control group. They just lived their lives. But at the CNBSS, they advertised and asked women to volunteer to participate. Red flag number two, self-selection bias. This was not a representative sample of the population, since women are motivated to volunteer for various reasons. At that time in Canada, mammography was not easily accessible, and women with lumpy breasts or with a family history of breast cancer would be among those motivated to enroll. So many were higher than average risk. Moreover, recruitment wasn't going well at the beginning of the study, and the investigators asked for help from breast surgeons. They asked them to refer their patients to participate in the study. And who sees breast surgeons? Women with lumps. Finally, the participants were not ethnically diverse. One of the researchers recently stated that 98% of the women were white. All the volunteers had a clinical breast exam by a nurse before being assigned to the study or control group. Even if the nurse detected a mass, the woman was supposed to be randomized, possibly into the control group. Red flag number three, nothing should be known about individual participants until after randomization. And this put the nurses in an ethically untenable position. We now know that the randomization was circumvented for many women with lumps and that they were deliberately placed in the mammogram arm. Assignment was on open lists, so it was possible for the coordinators to deliberately and undetectably bypass the randomization process. Those of you who've done clinical research know that nowadays, randomization is done centrally by computer. But in the 1980s, there were no computers. Paper and pencil were used. This is what the open assignment list looked like. So if there was a woman with a lump, it was possible for the research coordinator to write her name on the next available mammogram line. And if that meant leaving one or more lines blank for the control assignment, they could wait for another participant to fill in the blank line, and it would be untraceable. Experts realized that there must have been a problem with randomization in the first round of the study. There were 24 advanced cancers defined as those with 4 or more positive nodes. 19 of them were in the study group, 17 of which were palpable, and only 5 were in the control group. The excess was statistically significant, and the chance of this happening with random assignment was calculated as being 0.003%. And the imbalance persisted. At the end of the study, there were 102 advanced cancers in the mammogram arm and only 68 in the control arm. So it's no surprise that more women died of breast cancer in the study group than in the control arm. Sure enough, in the first 7 years of the trial, 8 women in the study group died of advanced cancer and only 1 in the control group. The 5-year breast cancer survival rate in Canada in the 1980s was 75%. In the CNBSS control group, it was greater than 90%. The only plausible explanation is that advanced cancers were deliberately allocated to the mammogram group, leaving fewer cancers in the control group. Another problem that arose because of recruitment of volunteers was the contamination of the control group. 26% of the women aged 40 to 49 who were assigned to the control group had mammograms outside the trial. Now, if a small cancer was found in any of these asymptomatic women, the women would be treated, do well, and not die. Their deferred deaths are still counted in the control group, though, even though their cancers were discovered on a mammogram. And that's why it's called contamination. And it happens to some extent in all randomized trials, but it was far more frequent in this trial. The improbability of the outcomes that were published in 1992 prompted a forensic audit, which was published in 1997, but their investigation was cursory and the auditors admitted it. They visited only 13 of the 15 centers. They had been strongly advised in writing that they should interview the staff and offer them indemnity for any protocol breaches, but the study authors would not permit that. Their audit consisted only of reviewing those allocation lists, looking for erasures. But as I've already shown you, no erasures were necessary and any tampering would not have been detected. The auditors claimed that even if subversion had occurred, it would have affected very few individuals. But Dr. Yaffe at U of T mathematically proved that moving only 7 women with cancer out of 50,000 participants from the control to the study arm could change the outcome from mortality reduction to mortality excess. And moving just 10 women would cause a mortality reduction benefit, excuse me, of 26% to appear as a mortality excess of 36%. Yet this audit has been used to defend the CNBSS, and the study co-authors continue to deny any serious issues that would render it invalid. Now, in March 2021, a mammography tech who had worked for the CNBSS emailed Dr. Dan Kopans from Harvard after she heard him give a lecture on the problems with that trial. She had witnessed the nurses and coordinators bypassing the randomization and deliberately moving women assigned to the control group into the mammography arm if they had found a lump. Now, this prompted my colleagues and me to seek out surviving former staff of the CNBSS. Now, remember, that's 40 years ago. And we heard from 28 who had witnessed protocol deviations, including participants being deliberately moved to the study arm. I'll skip through the next slides quickly in the interest of time. There have been 3 peer-reviewed publications since then, this one in the Journal of Medical Screening, this one in the Journal of Breast Imaging, and another, all confirming that based on flaws in the design and execution, the CNBSS trials are invalid. Their results are outliers, as I showed you, among all the other randomized trials, and they should be retracted from the literature and not used for determining screening policy. Efforts are ongoing, and the matter is now in the hands of U of T. You may be aware that University of Toronto does not have a good track record dealing with scandals. In a previous case of a whistleblower who was trying to protect patients, the university fired her because they didn't want to risk losing a big donation from a pharmaceutical company. Eventually, U of T appointed a 3-person external review committee. 2 of those 3 in the panel are clearly conflicted because they've previously publicly endorsed the CNBSS. The chair of the panel had written an editorial supportive of the study entitled "Too Much Screening." Another had published a paper suggesting that Switzerland might abolish mammography screening. By the way, they haven't. When we pointed out these conflicts to the university, they said that they didn't consider them to be significant because they weren't financial. It's been almost 3 years since we sent everything to U of T, and we have heard nothing. So the main issue with the task force is the choice of what evidence to include and exclude. They also do not follow international standards for creating guidelines. Both NICE UK and Agree 2 recommend having experts and patients on the guidelines panels, but our task force did not. For the current review of the breast screening guidelines, they've invited experts and patients to participate, but it's a performative gesture. The task force still chooses which studies will be included for assessment and ignores literature recommended by the experts, and neither the experts nor the patients get to vote on the guidelines. Now, the Canadian task force says that they use GRADE, and you're probably familiar with GRADE, the grading of recommendations, assessment, development, and evaluation. It's a system for rating the quality of evidence, and it was invented at McMaster in 2004. In GRADE, systematic reviews are deemed to be the best evidence, followed by the randomized controlled trials, followed by non-randomized trials, observational studies, and so on, then case series and expert opinion at the bottom. But GRADE states that both randomized trials and observational studies can be moved up or down on the quality scale based on implementation problems, magnitude of benefit, etc. By using only randomized trials, including the Canadian trials, and refusing to use the more modern, high-quality observational studies, the task force has not used GRADE appropriately. Case control studies are high on the GRADE pyramid. They match patients who've had mammograms with controls retrospectively. They show 50% mortality reduction among screened women. This Canadian observational study from 2014 showed large magnitude benefits. They studied almost 2.8 million who attended a screening program in Canada, and they showed 44% mortality reduction in women 40 to 49 who had mammograms. And they even did a sub-study that confirmed that there was very little selection bias. Yet this study was ignored by the task force in 2018. The Swedes looked at 58 years of data collected on just over 50,000 women in one county in Sweden. Now, rather than look at all breast cancers, they focused only on the ones that became fatal. And by doing so, they eliminated lead time bias and overdiagnosis, because it can't be overdiagnosed if they killed the patient. They showed that women aged 40 to 69 who chose to be screened were 60% less likely to die in the first 10 years after diagnosis and 47% less likely to die within 20 years of diagnosis. Randomized controlled trials show mortality reduction, but by using only randomized trials, the task force ignored additional important benefits of early detection, improving the quality of life for women with breast cancer and allowing them to have successful treatment with less aggressive therapy. When cancer is detected early, women can avoid a mastectomy and have a lumpectomy instead. The task force didn't consider this as a benefit of early detection. Lymphedema occurs in up to a third of women after axillary dissection done for lymph node staging. It's permanent. You can see the various grades of lymphedema here. And as you can imagine, it's life-changing. It's the worst part of breast cancer for many women. Now, when cancer is detected early, women can have a less invasive sentinel node biopsy instead, with a risk of lymphedema as low as 5%. Another benefit of early detection that the task force ignored. Women deserve the opportunity to avoid this complication. Chemotherapy is awful to go through, and some patients suffer long-term complications. Now, many women can avoid chemo if their cancer is small, if there are 3 or fewer positive nodes, and if they're at low risk of recurrence by genomics. This is another hugely important benefit that the task force ignored. These researchers showed that women who delay screening, meaning don't start at 40, or have screening mammography less often, meaning less than annually, are more likely to undergo mastectomy, require axillary dissection, and need chemo. This is certainly an issue with the task force's recommendation that women 50 to 74 have screening only every 2 to 3 years. In fact, no mammography screening program in Canada recommends a 3-year interval. So what are the risks? Well, the task force, as I told you, understated the benefits, and then they compared them to what they regard as the harms of screening. Now, the 2 harms that the task force feels outweigh the benefits of early detection are what they call false positives and overdiagnosis. Now, I have a beef about them using the term false positive. It's fear-mongering and pejorative. That term would mean that a woman was told she has cancer when she doesn't. But the task force uses it to describe when a woman is recalled for more tests after screening and that proves not to be cancer. So I believe they should be called a false alarm or a recall. This chart shows that the false alarm rates for women in each of the decades from the 40s to the 70s are almost identical. The tall blue bars represent the recall rate of the woman's first screen, and recall is higher the first time and then decreases no matter how old she is when she starts screening. So recalls are not a good reason to make women wait until age 50 to start having regular mammograms. When you discuss screening with your patients, please warn them. Recalls are common, especially on a woman's first mammogram. And 96% of recalled women will be reassured that they don't have cancer. And the 4% who do have cancer are lucky to have had it found as early as possible. So here are the real life numbers. For every 1,000 women screened, 93% or 930 will get a normal result. 70 of them will be recalled for additional tests. Most of those are benign, like masses, like cysts and fibroadenomas. Now, 11 of the 70, in other words, 11 of the original 1,000, will need a needle biopsy, and those are done with local anesthetic and should not be significantly more painful than a blood test from the arm. And 4 of those 11, or 4 of the original 1,000, will be diagnosed with breast cancer. Now, the anxiety from a false alarm is very real, but it's transient, and women can handle it, especially if they're informed ahead of time of the possibility that they will be recalled. So anxiety is not a good reason to deny women mammography, because then we lose the opportunity to find those 4 cancers early. Using a quality of life instrument, these researchers concluded that false alarms were associated with increased short-term anxiety, but not long-term anxiety. They did not cause measurable health utility decrement, and they increased a woman's intentions to undergo future breast cancer screening. The task force criticizes breast cancer screening for its recall rate, but it doesn't highlight the success in cancer detection. And what's worse, they use different thresholds for different cancers to determine whether screening is worthwhile. This means that a breast cancer life is valued differently than a lung cancer life, etc. Breast cancer is far more common for women aged 40 to 9 than cervical and colon cancers are in the ages that the task force recommends screening for. Yet the task force recommends against mammography screening that has a 0.9% benign biopsy rate and a positive predictive value of 36% of those biopsies, but it recommends colon screening with a FIT or fecal occult blood test every 2 years for women aged 50 to 74, with a biopsy rate 5 times higher at 4.7% and a PPV of only 25%. And they recommend Pap smears, which, by the way, they are overdue replacing with HPV self-testing in most places in Canada. They recommend that every 3 years for women aged 25 to 70 with a 4% recall for colposcopy and a PPV of only 0.4%. And the fatality rate for colonoscopy is about 3 per 100,000. The task force recommends starting screening later and screening less often to spare women transient anxiety, even though they know that more women will die. Well, women disagree. Researchers found that 97% would have regular screening, even if it meant having a false alarm. And 82% say they'd be willing to have a needle biopsy if it might increase the chance of detecting a cancer earlier. So that's what your patient must consider when you have a shared discussion with her about whether she should have mammography screening. Remember, 4 of 11 needle biopsies show cancer. So here the task force member is standing at the grave saying, yes, regular mammograms and early detection would have saved your life, but aren't you glad we spared you all that anxiety? Women can tolerate some transient anxiety, and they should be allowed to decide for themselves whether to have a mammogram and the opportunity for early diagnosis. If we're really worried about anxiety, we should be doing more to shorten the wait time for diagnostic workups for women who are recalled. Now, another risk of screening is overdiagnosis. It's the theoretical possibility that a cancer we find at screening would never surface on its own, so there's really no need to find it. For example, some cancers do grow so slowly they may never become life-threatening. Or a woman might die of something else before her cancer becomes life-threatening, like heart disease or a different cancer. But these are not reasons to not screen younger women because their cancers do grow faster and they're less likely to have other potentially fatal illnesses. So the risk of overdiagnosis in younger women is almost zero. If they're not screened, we'd lose the opportunity to find their lethal cancers. But overdiagnosis should be discussed with your elderly patients, especially if they have other illnesses. The challenge is that overdiagnosis cannot be measured directly and it must be estimated. Italian researchers looked at 16 estimates of overdetection from 13 European observational studies, and after correction for baseline incidence trends and lead time, overdiagnosis estimates fell into the range of 1 to 10%, and they'd be closer to 1% in younger women. Now contrast that with the Canadian task force. Because they used the data from that flawed Canadian trial, they vastly overstated the degree of overdiagnosis to be 32 to 55%. Breast cancer is less common in younger women, but they have more years of life to lose and their cancers grow faster. The years of life lost are higher for women in the 40s than in the 50s or any other decade. More than 40% of the years of life lost to breast cancer occur to women diagnosed younger than 50. So in summary, the task force recommendations were based on their weighting of the benefits and risks, but they understated the benefits by using mortality reduction in the old RCTs, including the Canadian trial, and they ignored modern observational studies. They ignored the benefits of less aggressive therapy when cancer is found early, and against that, they overstated the risks of screening by inflating the harm of transient anxiety from a recall, and they overstated the incidence of overdiagnosis. And those errors are reflected in the 1,000 Women tool sent to all primary care providers in Canada by the task force with numbers derived from the Canadian trials. The task force does not audit the outcomes of their guidelines. Now, till 2011, the task force supported screening for women in the 40s. And because provinces in Canada don't all follow the guidelines, we have a natural experiment in Canada. Stats Canada and researchers in Ottawa compared the stage of cancers diagnosed in provinces that screen starting at 40 compared to provinces that start at 50. In these graphs, the orange bars recommend the provinces that screen at 40, and the blue bars recommend those that start at 50. Now, after 2011, in provinces that don't screen until age 50, there were more stage 2, 3, and 4 cancers and fewer stage 1 cancers in women 40 to 49. And there was a knock-on effect in women aged 50 to 59 with more stage 2 and 3 cancers and fewer stage 1 cancers. There was also a 10% increase in metastatic cancers in women in the 40s and 50s after the current guidelines were introduced. The same authors looked at 10-year net survival for women with breast cancer diagnosed in their 40s and found that it was significantly higher in provinces that start to screen at 40. And survival was significantly correlated to the participation rate. Remember, in BC, only 25% of eligible women participate. So these stats on survival are an underestimate of the benefits that are possible. And the task force ignored this study too. Now, one problem I encountered when advocating for better screening was hearing, well, the task force guidelines must be okay because the Canadian Cancer Society endorses them. In fact, after publication of those Ottawa studies, Canadian Cancer Society and 2 other breast cancer organizations called on the task force to review the guidelines, and they withdrew their endorsement. Now, the Canadian Association of Nurse Practitioners is also considering withdrawing their support. The other 2 organizations that endorse them are the Canadian College of Family Practice and the Canadian Partnership Against Cancer. So disappointing. Now, please watch carefully for the next set of guidelines, which should be revealed in the next couple of months. And please don't endorse them if they're unchanged from the current guidelines. So all average risk women should be screened annually, starting at 40. And starting at 40 is especially important for Black, Asian, and Hispanic women who get breast cancer younger than white women. Their peak incidence is in the mid-40s compared to Caucasian women whose peak incidence is in the early 60s. So they must get screened starting no later than 40 if we're going to find their cancers early. And Black women are more likely to get aggressive cancers and have a 42% higher risk of dying of breast cancer than white women. A woman's access to early detection depends on where she lives. Currently, women can self-refer at age 40 in only 4 jurisdictions. British Columbia happily has always allowed it, but women don't know. So please encourage your patients 40 to 49 to self-refer to the screening mammography program. So when do we stop screening? Well, the task force says screening should stop at 74 because the old randomized trials included only women up until that age. And most provinces have defaulted to that. But breast cancer risk keeps increasing with increasing age. And if a woman doesn't die of something else, her risk of breast cancer keeps climbing. So if a woman's in good health and is well enough to have treatment if cancer's found, then it's worth continuing screening to find those cancers when they're small. And a rough guide would be a life expectancy of 10 years. Now in Canada, the average life expectancy for an 80-year-old woman is 10 years. So stopping at age 80 would be reasonable, but it depends on her general health and her personal values. I have a friend who's 84 and extremely active. She just bought a bike last year and she rides 10K 3 times a week, and she's still having mammograms. In British Columbia, women can and should self-refer until age 80 if they're in good health. So how do we screen for breast cancer? Well, there are many ways, but mammography is the gold standard, having the most evidence to support it. Ultrasound, MRI, and some newer tests are also important, but time prevents me from discussing them in detail. Let me remind you, thermography has been thoroughly discredited by both the FDA and Health Canada. It cannot substitute for mammograms. And please let me know if you'd like another webinar on some of these other modalities. So I want to discuss breast density, and we're pretty good at recognizing cancer when it shows up on a mammogram like this. This obvious cancer is in a 55-year-old woman, and the reason it's so easy to see is the cancers are white, and in this woman, the rest of her breast is a dark gray. But women's breasts vary tremendously in their background density. Why am I showing you a chest x-ray? Well, because almost all chest x-rays, normal chest x-rays, look the same. Normal breasts, however, vary tremendously in appearance. Look how different these breasts look, and they're all normal. Breast density is divided into 4 categories, A through D. And the categories reflect the ratio of normal breast tissue, which is white, to the fat, which is dark gray or black. The likelihood that a cancer can be missed increases in women with dense breasts. So categories A and B are considered non-dense, and categories C and D are considered dense. And 43% of women over age 40 have dense breasts. It's normal and it's common. Now, this video shows the visibility of cancer depends on how much normal dense tissue is in the breast and where the cancer is located in that breast. Cancer can be missed in a breast of any density, but it's much more likely in dense breasts. Mammography sensitivity approaches 100% in fatty breasts, but it can miss about 50% of cancers in women with the densest breasts. And the double whammy is that breast density is also an independent risk factor for breast cancer. Women in category D are 5 times higher risk to get breast cancer than category A, or another way, they're twice as likely than average. So it's a perfect storm for women with dense breasts. They're more likely to get breast cancer, and we're less likely to be able to detect it on their mammograms. Now, breast density can only be determined on a mammogram either by the radiologist, subjectively eyeballing the image, or by software. You cannot tell a breast density by the breast size or texture. Lumpy breasts are not necessarily dense. Both fatty and dense breasts can feel soft, firm, or lumpy. Now, when cancer is not detected on a mammogram, it continues to grow and potentially spread. And usually these are found as a lump or other physical change after a woman's last mammogram was negative. And we call them interval cancers because they're found in the interval between planned screening mammograms. Interval cancers tend to be larger and more often spread to the lymph nodes than cancers found at screening. They tend to be more aggressive with a greater incidence of triple negative and HER2 positive subtypes. Women with interval cancers have a worse prognosis than women whose cancers are found on screening. So reducing interval cancers is an important goal of screening. Here's an example of dense tissue hiding a cancer. This is an acquaintance of mine who had a negative screening mammogram at age 50, and you can see that she has category D, extremely dense breasts. But negative in a woman with dense breasts doesn't always mean there's no cancer. 8 months later, she came back with a palpable lump in her left breast, and we repeated the mammogram. You can see this triangular sticker that the technologist tapes on the skin over the lump. So when we look at the mammogram, we'll know where the lump should be. And here you can see that it's taped on her skin and it's still negative, even though we did a 3D mammogram. Now, you're most likely aware of the disclaimer on some mammogram reports saying that a negative mammogram cannot rule out cancer if there's a palpable lump and that the patient should have ultrasound. So sure enough, she had a palpable lump when we did her ultrasound. We saw her 3.2 centimeter cancer and it had already spread to her lymph nodes. This is an interval cancer, and interval cancers are 13 to 18 times more common in women with dense breasts. Now, we don't make policy based on an anecdotal case. We knew in the 70s that ultrasound could show cancers in women with palpable lumps that weren't visible on their mammograms. But it was thought at the time that ultrasound could not find cancers that weren't visible on the mammograms and were still too small to feel. But that was before the development of high-frequency ultrasound probes. We published this paper over 30 years ago, and it was followed by work from multiple other institutions and then multi-center trials that showed that high-resolution ultrasound can find cancers that are too small to be palpable and missed on mammograms, largely because of dense breast tissue. This is a randomized trial in Japan where ultrasound screening has been shown to find more early cancers and reduce the interval cancer rate by half with only slightly lower specificity. It's now generally accepted that a lower interval cancer rate predicts future mortality reduction. Thanks to the tireless work of Dense Breasts Canada volunteers, Of the 12 provinces and territories that have screening programs, 8 of them now inform all women of their breast density in the mammogram results letter, and 3 more are in the process of directly informing women. British Columbia was the first to start informing women in late 2018, and since early 2019, screening breast ultrasound has been covered in BC by MSP, and it's available to women with category C and D density, but women do need a requisition. My colleagues audited our screening breast ultrasound results in the first year after screening breast ultrasound was insured, and we found 7 cancers for every 1,000 ultrasound exams performed. Now, bear in mind, mammography finds on average about 5 cancers per 1,000. So this was an additional 7 cancers that were missed on the mammograms. They were small, invasive, and node negative. And I want you to note that 40% of them were in women with no family history, and 60% of them were in women with category C. Besides mammography and ultrasound, there are many other ways to detect breast cancer. Breast self-exams and clinical breast exams are discouraged by the task force. I'm a big proponent for breast self-exam, more so than clinical breast exam, since most women in Canada are not having optimal screening. Most aren't having mammograms till 50, and then they have only 2D mammograms and only every 2 years. Their cancers are often found by what I call accidental breast self-exam. Breast awareness should be encouraged, and patients should be reminded to report changes in their breast to you, even if they've recently had a negative mammogram. The term breast self-exam has gone out of fashion, and women are told just to be breast aware and are told to see their doctor if they notice any change. But how's a woman supposed to know if there's been a change if she doesn't know what her breasts usually feel like? And to complicate matters, there's not one normal for all women. Some breasts feel soft and uniform, others feel lumpy like a bag of marbles. So no 2 women's breasts are identical, but when a woman does do periodic breast self-exam, she quickly becomes familiar with her normal texture and is more likely to notice a subtle change than a healthcare professional who might examine her only once a year or even less. Now, there are lots of demonstrations on how to do breast self-exam on YouTube, but an excellent one that I recommend is by Dr. Liz O'Riordan. She's a breast surgeon in the UK who's had breast cancer. Please recommend it to your patients. It's only 3 minutes long. And the second link here is her demonstration of how to do breast self-exam or chest self-exam after a mastectomy. Other modalities that increase cancer detection are tomosynthesis, sometimes called 3D mammography, MRI, and contrast-enhanced mammography. And please let me know if you'd like another webinar about those. So my final points: a woman's risk of breast cancer nearly doubles if she has a first-degree relative like a mother or sister who's been diagnosed with breast cancer. But not having a family history doesn't mean that a woman doesn't need screening. You may be surprised to hear that 85% of women who get breast cancer have no family history. That's why all women need to be screened, not just those at increased risk. And dense breasts are actually a more prevalent risk factor than family history. So after all the evidence I've discussed, you can see why experts feel that the task force guidelines are outdated and dangerous. Those of us who actually work in diagnosis in breast cancer see the harms to our patients, especially the younger women. And the new data from Ottawa confirms what we've seen for decades. So to save the most lives and reduce suffering from breast cancer, the best case scenario would be to do a risk assessment for all women aged 30. Women should be encouraged to do breast self-exam. All average risk women should be able to self-refer for annual mammograms starting at 40, ideally with 3D, and continue as long as they're in good health with a life expectancy of 10 years. All women should be informed about their breast density, and supplemental screening should be available for women with dense breasts. But this is what we currently have in Canada. It's a postal code lottery for women. We have a lot of work to do to bring equitable access to early detection in Canada. BC's doing not badly, thankfully. We do have to dispel the myths around breast cancer, that young women don't get breast cancer, that women without a family history are at low risk, that mammography is enough for all women, that chemo is so effective that we don't have to detect cancer early, and that false alarms are a good reason to not offer screening. So I'll stop there. Thanks for your attention. My email address is on the slide, and you will get a copy of this recording so you don't have to write it down. And I'll be happy to answer any questions by email. But please share this recording with other healthcare providers and let your colleagues know that I'd be happy to speak to them in a live format if there's interest. So I'm going to stop sharing my screen now, and I will look in the chat. Do I have access to the chat? Chat. And see if there are any questions. I don't see any questions. Is it possible for people to ask a question live if they have any?
I would like to ask a question. I have a woman with group D, dense breasts. I was trying to get her an ultrasound. I was told in Penticton it's not available. She should go to Vancouver to the private pay units.
No, not private pay. It's actually scandalous that screening breast ultrasound is not offered more widely. And one of the reasons is there's a huge shortage of ultrasound technologists. We're working to try to get the system to train more techs, and there are wait lists for, you know, pelvic and abdominal ultrasounds and so on. The clinic that they're talking about in Vancouver is not private pay. It's certainly covered by MSP, but because there's so few places doing screening breast ultrasound, there are long wait lists. But we do have patients from all over British Columbia, and you can certainly refer your patients there. It's Dr. Linda Warren and Associates, also called X-Ray 505, and the phone number is area code 604-879-4177. Now, some women are alarmed when they hear how far in advance we're booking, but in fact, we recommend that women do not have the screening ultrasound at the same time as their screening mammogram. It's better if they have it halfway between mammograms, and that way women are getting so-called screened twice as often. So instead of having mammogram and ultrasound and then going 2 years with nothing, they can have the mammogram, a year later the ultrasound, a year later the mammogram, and alternate them that way. So if she's willing to travel, there's some other places that do them. Dense Breast Canada, which is the patient advocacy group, is more aware of who's doing what than I am, and your patient can contact them. It's just email them at info@densebreastcanada.ca, and they may know of other clinics closer to you that will do it.
And will BC Cancer recall women with dense breasts for annual mammography?
No, that is done in 7 provinces, but not BC Cancer. And my colleagues and I are advocating for better care. But, you know, there's not enough voices. We need more people to be writing the Minister of Health, to be writing BC Cancer and the head of screening at BC Cancer. We need a lot more help with advocacy. And it's great if doctors do it, but honestly, it's more effective if patients do it. That's my experience. And I've been at this now for about 7 years, helping Dense Breast Canada advocate. The healthcare systems and politicians ignore the experts, but politicians listen to voters. So if you can get your patients involved, that would be hopefully more successful.
Thank you.
You're welcome. Any other questions? Well, thanks for your attention. As I said, my email address is on the last slide. I don't know how long it'll take you to get the recording. My email address is P like Peter, B like Bob, Gordon, Gordon, at mac.com. And somebody's just put in the chat, they've had success getting screening ultrasound for category D breasts in Kamloops. Thank you for letting us know. So unless we see any other comments or questions in the chat, I will close off. Well, thanks again for your attention. I am happy to give similar webinars if you know of other caregiver groups who are interested. Have a good day, everybody.
Thank you.